Welcome all of you. Thank you for being here. My name is Elizabeth Turcott and I'm the nurse manager of the Orthopedic Institute at Central Maine. I want to start off by thanking first the Green Ladle for hosting us and for the wonderful food that they've provided, and all of you for attending. And then I could stand up here and list everybody that has had input into this presentation and this entire night, but then they'd boo me off the stage with the music that they use to cue you. So I just want to thank everyone for all the work that's gone into making tonight successful. And we're here tonight to talk to you about the OICM hip fracture program. And we've prepared this presentation for you at all levels, as well as providers and nurses. This is the course agenda. You can read through it. You also have it in front of you. You have the entire presentation at your seat. And each one of us will have a certain part of this presentation. So, what is the OICM, or the Orthopedic Institute of Central Maine? We are a unique partnership between Central Maine Orthopedics, located over in Auburn, and Central Maine Medical Center, located in Lewiston. We got together in September of 2009, and we opened the inpatient unit and started our journey towards standardizing patient care in the world of orthopedics. So we use this little visual here to represent the Orthopedic Institute of Central Maine, and I love our little motto of coming together as a beginning, keeping together as a progress, and working together as success. So OICM is a service line, a new paradigm, as I stated before. It's a different way to deliver health care. We look at everything we do through the patient's eyes. How is it going to affect the patient? Anyone that's involved in affecting the patient's experience is on the team. It is a multidisciplinary team, so we include everybody that touches the patient, from therapy, from the scheduler, to the surgeon, to the nurses, to the CNAs, and then back to the office again. We do meet monthly as a PIT crew team, and that is that multidisciplinary team made up of all those personnel, and we talk about performance improvement and testing innovation. And we look also at metrics, and I'll show you those in a couple of minutes. In order to improve our patient care, we have to measure our metrics and our patient outcomes. And our team position is that we're never satisfied. So we're never gonna be doing just good enough. We're always gonna make it better. So this is just to show you the importance of having a program, a formalized program, and that is what we are doing with the hip fracture program. But we have already done it with our total joint and spine program over the last 5 years. And you can see our metrics here, pre-program and post-program. For example, the first one is average length of stay. Pre-program, our patients were staying 3.34 days, and our patients now are staying 2.15 days. So we have reduced that significantly in the last 5 years. Another good one to look at is percentage discharge to home. We certainly want our patients to be going home rather than to be going to skilled facilities or rehabs, and we have increased that for joint to 85% from 64%, and for spine to 93% from 67%. And there are some other metrics there as well. Not only do we measure ourselves pre-program and post-program, but we also measure ourselves against other orthopedic centers nationally. And on this slide, some of the same metrics, you can see how we compare to national centers. And we are well below their rates and percentages across the nation. Like I said before, we're never satisfied with our outcomes, so just because we are below some of the US ortho centers, we don't stop there. We continue to look at best practice and what is best for the patient. We ask our patients, we listen to our patients, we use their feedback from their experience. Always focused on quality, patient safety, and satisfaction. So with all of that, I'm going to introduce Dr. Jeffrey Bush. He is the medical director of the Orthopedic Institute of Central Maine, and he is also the physician champion for the hip fracture program.
I just whispered to Elizabeth that they were clapping for her, not me. Well, thanks for coming. I appreciate everyone coming out, especially my own office staff in the back. We're very supportive of everything we do, and I appreciate that. And so I'm going to talk a little bit about hip fractures, this sort of national challenge and local challenge we have with managing these patients who end up being, you know, when they see us with a broken hip, it's a very critical point in their health care, and unfortunately a lot of folks really take a turn for the worse when they have this injury, as much so as if someone has a heart attack or a stroke. And so one of our plans at our place is to give that fact the respect it deserves, and that critical medical situation the level of care, and to have it on everyone's radar that this is not, you know, someone who needs to lie around until we find a chance to fix their hip fracture, but this is a really critical moment for them, and we need to get them on a pathway and have a programmed approach so that we can really treat them and move them along and give them a good positive outcome. And we'll talk about a little basic anatomy and stuff, and for me the fun part, fixing the hip fractures, and then we'll move it along to the next crew. There's a lot of information on some of these slides. I might not touch every word on that. But basically, you know, the typical, this is almost, some of this is maybe a worst case scenario sort of thing, but the typical hip fracture would, you know, come into the hospital, be diagnosed with a hip fracture, you know, be given a Foley catheter, you know, perhaps given some pain meds, we get their x-rays, maybe even putting a little bit of light, gentle, you know, Bucks traction. Admit them to the hospital, have the medical docs see them, and when they were clear and stable for surgery and there was OR time available, we would fix them. And in some institutions, although we've been better than this, in some institutions maybe it was, you know, 48, 72 hours or more until the fracture was taken care of. And you know, the problem with this is that none of us want our mother or grandmother or eventually ourselves sitting around for that long in pain before surgery, but also that the health problems associated with that can be extreme. The delirium, you know, the bed sores, pneumonia, and everything that can happen from lying in bed. And patients who lie around longer, in the end, are found to have more medical problems post-operatively or even pre-operatively before surgery. So it's a real initiative on our part to try to intervene before that happens. And of course, the very last part there is that, you know, the worst case scenario, this hip fracture is a terminal event for some of these people. In other words, they have their hip fracture and they end up in a hospice situation, or they don't survive the year. And so we would like to intervene early and appropriately and really change that outcome for some of these patients and families. In the first year after a broken hip, depending on where you Google this, you know, the mortality rates can be 20% or higher. And the ability to go back to an independent lifestyle if they came from an independent lifestyle before, it can be very low. The post-op rates of delirium are high. And there have been centers who have been able to intervene as we're starting to do and to change some of those rates. And that's really what we're trying to do. And our main goal in this, I would say, is to, you know, we have this patient population that we're taking care of every day, and there's really a way to do it better. And that's what we're doing now and what we're going to continue to be doing. As Elizabeth pointed out, it's a big team. It's you know, not just the surgeon and anesthesiologist, or not just, you know, the ER doc who sees them when they come in, but it's from the moment they hit the door. You know, we're going to say the clock is ticking. This person has a hip fracture, and it's the therapists and social workers who are all involved. The OR's involved from the start. Our orthopedic crew on the floor, so we can make sure that once the people get on this pathway, that we can give them more success than traditionally hip fractures have had in the past. And so, as Elizabeth pointed out, we have certain goals as far as timeliness to the OR and measuring how well these people are walking and what percentage of them are going home, and comparing that with historical data from our place and other places to make sure that we're reaching our goals and that we are improving their lives. Basic stuff about the hip. We'll keep it simple, but it's a ball and socket joint. And the ball being here and the socket up here, obviously. When people break their hip, they break them in 2 or 3 places. We see femoral neck fractures. I can use this if it shows up better. But people break the neck or the intertrochanteric region, the lesser and greater trochanter there, we often see an intertrochanteric hip fracture. Or down here, the more high energy injuries, subtrochanteric fractures down into the shaft of the femur. Usually what we see are, the most common is the intertroch, and then we see femoral neck fractures as well. Occasionally, through the, biomechanics of an unfortunate way of landing, somebody will break on the pelvic side as well, and it's a lot more involved to get down there and fix the pelvic and pelvic fractures. Fortunately, the majority of the fractures we see are on the femoral side. Just sort of the patient profile, the typical demographic are that most of these are female. It can certainly happen to anyone, but it kind of follows along, osteoporosis and some other medical things. But high risk groups are female, Caucasian, and as you would imagine, the older we get, we're more at risk for hip fracture. Any medical conditions can do it, but basically these are things that are kind of leading to osteoporosis and weak bone, but certain certain medications and nutritional problems, and certainly if you're looking for one more reason not to smoke or be an alcoholic, this is on the list. The complications of lying in bed, as I alluded to before having a hip fracture fixed, are it's the bed sores, the pneumonia, DVTs, blood clots, any major delirium should be on the list, but any major medical problem we see is more likely to occur the longer we wait for surgery. And as I tell my patients, whether they're hip fracture patients or other patients, are that people don't get sick walking the halls, people get sick lying in bed, and so what we want to limit is the amount of downtime when they're lying in bed. The fun stuff for me is fixing them. I wish we didn't have to fix so many hip fractures, but in the end, this the mechanical part, the carpentry of it, oftentimes is the easy part, because systemically these patients go through quite a bit when they break their hip, and fixing their bone is really just the start of what we need to do. I think I have pictures of most of these, but when they break the femoral neck, we often, if it's displaced, they'll often get a hemiarthroplasty, or half a hip replacement. Oftentimes these days we're doing total hips on these patients and replacing the socket side as well if they had some pre-existing arthritis. And the reason to do it like that, to replace the part of the broken hip, is the femoral neck area has it's weak bone to begin with, obviously because it just broke. It doesn't have a great blood supply, and so if it's broken through there, you can replace that part of the hip and theoretically have the patient walking the next day or even the same day. Fractures down a little lower in the intertrochanteric region, we fix either with a plate and screws. Open reduction internal fixation is how it's always written on the paperwork. So ORIF is just a simple plate and screws fixation, or sometimes an intramedullary device, which is nice and probably the most common way to fix these now, an IM nailing, because you can put a titanium nail down into the shaft of the femur and put these other screws across and do it through, a little incision up here, a little incision there, and a smaller one there. So you're really indirectly fixing the break and lining it up under X-ray. So you don't need to go in and, muck around with the broken pieces and disrupt their blood supply. You can line them up under X-ray and fix it. And I think we probably do one of those at the hospital probably almost every other day, it seems. It's probably one of the more common operations that all of us do in our group. Again, we've talked a lot about the adverse medical issues that we're trying to avoid, and really I think the delirium, the pulmonary issues are probably the biggest ones. But we worry about any anything they're gonna get, the bed sores, the pain from lying there, and like I mentioned earlier, that the reality is that this often can be a terminal event for some of these people. 20% over the course of a year is a high number, and that's probably on the low side. And so that's really what we want to take these people at this critical point in their care and in their lives, and make a difference for them. And I think our sort of programmatic approach to that, where we have a lot of people on board and make sure we can intervene as quickly as possible and give them the appropriate medical management, I think will really make a difference in a lot of their lives. So next up, Diane Jazelskis. Diane, our Chief Customer Officer, she is going to do for these patients what she does for our hip and knee patients and a lot of others and our spine patients, but basically she is their concierge, I'll stop talking because you're up here, but she kind of is helping guide our patients through our various programs to make sure that they stay on track and that nothing is missed, and we'd be lost without her. And she is next. You can use this if you like.
Thank you. I prepared something to read, but I was going over it and I thought, I really shouldn't have to write down my name is Diane Jazelskis. So I think I'll go off script, and sitting down there and listening to Dr. Bush explain the importance of this program, I realize when you're going over the risk factors, we really need to get this right, because I'm what he's talking about. I am an older, Caucasian, white female, small frame, so I'm at high risk for a hip fracture. So I want to make sure we get it right. My role is a new position that was created for the Orthopedic Institute, and as a Chief Customer Officer, it's my job to make sure that whatever we tell the patient, that we deliver to the patient. So I could also be called a Chief Promise Keeper. It's my job to make sure that the patients come first. The patients are always at the center of everything that we do, and it doesn't matter what position this patient is in, whether they're at home, whether they're in the hospital, whether they get discharged to a facility or back into their home. I'm a resource for that patient, and I need to improve any processes that aren't working well to make sure that the next patient that comes through the process, that we get it right. So that's my job description in a nutshell. And my focus of this presentation is on the discharge piece. And the discharge plan for these patients, typically when they come in through the emergency room, they come up to the floor and we'll start their discharge plan after they're fixed. Well, we're changing that structure. We're starting their discharge plan when they're in the emergency room. We have it built into our order sets that we will have staff go down, speak to their caregivers, speak to their family members, speak to the patient, assess, where are they in this process as far as their safety at home. What can we do to help that? And we start as soon as they arrive at the hospital to make sure that we do get it right. We educate the patient's family members or caregivers with a booklet that has been designed just for this program, and it's specific to the hip fracture population. And then it's my job to follow up as the patient moves through this process and make sure that we are delivering what they need when the day comes for their discharge. So some of the things that we'll be assessing when the patient comes into the emergency room is their functional status. What were they doing baseline? What are they able to do themselves so that we can get them back to that level as soon as possible? We'll also be assessing their social support system. We want to know, who's available for them when they get into the home. What do they have for resources? Social work will be involved in this. And then, do they need a lifestyle change? Are they safe to go back into that home? We do have agencies in our area that go in and they'll do home safety evaluations. And we need to implement these to make sure that the patients do go home into a safe situation. I have had the pleasure recently of shadowing some of our home care workers and going into the patients' homes. And my overview of this and going into the elderly homes is that we really haven't done a terrific job taking care of our elderly patients sometimes. There are many needs out there that we don't normally have a chance to look into their homes and see. But it's really opened my eyes to the fact that we can do better. We can do a lot better for our elderly population and get them the services that they need before we get them out the door. So the rehabilitation piece of this begins post-operatively. If the patient is able, we will get them up the day of surgery and moving. If they're a little sedated, because sometimes the elderly population do not wake up from anesthesia as quickly as some of the younger patients. But we will definitely get them up post-operatively day one. They'll be able to bear weight. We'll teach them with the physical therapist how to safely navigate with a walker. We will make sure that we walk them in the hallways, in the hospital, and make sure that on discharge, wherever they're going, if it's home or if it's to a facility, that we give specific discharge instructions for that population. So it's critical for us to make sure that we get this right. Our elderly population really falls down when we don't take care of them in a timely fashion. So this program is totally designed to get this population through the process in a timely fashion so that they don't lose their function. Thank you. And next up is Swapna Kumari, who's a hospitalist at CMMC and very involved.
Hello. So today I'm going to be talking a little bit about what to do to prevent hip fractures. As someone who is family medicine trained and now I work as a hospitalist, prevention is, very important too, to make sure our elderly patients don't go into have all these complications. So I'm going to talk a little bit about osteoporosis and an overview about it, risk factors, prevention, assessment, and a little bit about fall prevention. So osteoporosis, we all know it as the brittle bone disease. It's a disease of the bone that occurs when you lose bone mass or you don't make enough new bone. It's a fight between the osteoblasts, which are cells that make new bone, and osteoclasts, which break down bone. Over time, basically with age, there are other risk factors that we're going to talk about, but your bones become weaker and they become more prone to breaking with a fall or even sometimes without a fall. So this is a picture of normal bone. This is the trabecular bone, I believe. And this is a bone with osteoporosis. And these are all the little holes there, and you can see that this is not very strong, obviously. So who usually gets osteoporosis? Women are definitely at higher risk. 80% of those with osteoporosis are women, but just to keep in mind, men can get it too, usually older men, people on steroids or other medications as well. Those with a family history of osteoporosis are more prone to developing osteoporosis as well. If you're not getting enough calcium through your diet or because of any other medical issues. Smoking and alcohol use can definitely lead to osteoporosis because of the poor nutritional status. And then also long-term use of certain medications like steroids or even some anti-seizure medications. So how do you test for osteoporosis and osteopenia? The gold standard is the Dexa Scan. It's a test that we use to analyze bone density, and it should really be done on any woman older than 65 years or older, or anyone you suspect have had a hip fracture or a vertebral fracture. And basically it's a test that measures the density of your hip and your spine, which are both bones that are most commonly affected by osteoporosis. So a little bit more about the Dexa Scan. It's non-invasive, it's safe, very minimal radiation is required, and it takes about 20 minutes to do, and it's pretty cost effective. So it's worth it having it done for the appropriate population of patients. And the way it's done is it's called dual energy X-ray absorptiometry. So it's two different beams passing through the bone, and that's how it measures the bone density. And just be aware you have to stop all your calcium supplements beforehand to get accurate results. So the T-score, that's what you know, the primary care doctor looks at in regards to whether you have osteoporosis, osteopenia, or healthy bone. That you get that number from the bone, from the Dexa scan. So basically what it's doing is it's comparing the patient's bone mineral density to that of a healthy 30-year-old. And it's usually in units of standard deviation. So a person with, let me see, so this is the Dexa scanner. That's the way it looks like. So the T-scores, a person with normal bone usually has a T-score of 0 or 1. Osteopenia is considered a T-score of -1 to -2.5. And then osteoporosis is anything less than -2.5. And that's when you want to be a little more aggressive. So as far as treatment for osteoporosis, you always should start with increasing your dietary calcium and vitamin D intake, and I'll speak a little bit more about this. And you could also take calcium and vitamin D supplementation, and of course increase physical activity and doing weight-bearing exercises is helpful. So for treatment with actual medications, usually we start the patients on bisphosphonates, Fosamax. And it really depends. You could start off with calcium and vitamin D, and if you've had no improvement in your Dexa scan, then you would continue on with bisphosphonate usually. Even with our hip fracture patients, we recommend at least 4 weeks out. Once they've gotten their Dexa scan, they should start a bisphosphonate as well. And then other medications include calcitonin, estrogen, and selective estrogen receptor modulators. So other ways of preventing osteoporosis, like we spoke about, is getting calcium and vitamin D, regular exercise, weight-bearing, resistance, and balance exercises, and eating fruits and vegetables, limiting your smoking and your alcohol intake. So calcium you can get through in several ways, usually with dairy products, green vegetables. There are sometimes calcium is added to your soy milk, juices, and breakfast drinks also. Vitamin D is the main source for vitamin D is sunlight. And so therefore you can expect that most people in Maine are vitamin D deficient, which is a very common problem in the primary care setting. So it's really important to address that because vitamin D helps in your calcium absorption. Other ways of getting vitamin D through food is through fatty fish, like mackerel, salmon, tuna, and also from your milk, orange juice, or other dairy products where it's added in. The recommended daily values for calcium is 1,000 milligrams to 1,200 milligrams daily. On average, I think a normal person usually takes around 600 milligrams of calcium just with a regular diet, so we're already deficient on calcium. Vitamin D, 800 to 1,000 units daily. Sometimes, especially here in Maine in the winter time, especially with our vitamin D deficient patients, we do tend to have them take even more than that, at least 2,000 units a day. And then if you're not getting enough calcium and vitamin D through your diet, you would consider taking these supplements that you could buy in the drugstore.